This conference will now be recorded.
Hello everyone, you are welcome on my first session with you, and this is about third session in our second batch of our MRCOG online course. You are welcome. Today inshallah we'll discuss about the two important topics, green top guideline in about delivery. That is, as you know, delivery module is very important modules beside the labor module, because a lot of question AMQ came in exam from delivery and labor modules. So today we'll discuss the two important green top guideline, shoulder dystocia, and the management of the third and fourth perennial tear. And this is very important modules. Inshallah, I hope to finish all the questions after each of the topics, and please feel free to interrupt me if there's any of your question. Okay, we'll start with the first one, shoulder dystocia. The most important question is, what is the definition of shoulder dystocia? So basically, you know, shoulder dystocia life-threatening emerges. It should be recognized and treated quickly, because to avoid a lot of significant morbidity and even mortality. So you should treat this quickly. It should be within 5 minutes. The definition of shoulder dystocia is defined as vaginal cephalic delivery that require additional obstetric maneuver to deliver the fetus after the head has delivered and the genital traction has failed. This is a common definition of shoulder dystocia. As you know, in normal labor, the delivery of the shoulder after genital traction, and if shoulder dystocia, if the shoulder dystocia occur after 1 minute after delivery of the head and there is no delivery of the shoulder, should be defined as shoulder dystocia. So shoulder dystocia occur when either the anterior or less commonly the posterior fetal shoulder impact on the maternal symphysis or sacral promontory respectively. This is also definition of shoulder dystocia. Most commonly occur in case of anterior shoulder impact against maternal symphysis, or less commonly if the posterior shoulder impact against sacral promontory. So this is about the definition of shoulder dystocia. By the other word, it is bony impaction. It is usually of the anterior shoulder against maternal symphysis or the posterior against sacral promontory. So this is about the definition of shoulder dystocia. And basically, you know, there is many morbidities and mortality for shoulder dystocia for the mother and for the fetus. Anybody knows about the maternal morbidity and fetal morbidity due to shoulder dystocia? What is the complication for the mother and for the fetus?
Hello.
Hello.
Hi, Dr. Fatah. The complication regarding the fetus mainly brachial plexus injury, in addition to nursery. For mother, postpartum hemorrhage, perineal tear, psychological problem also.
Yes, the most important complication for the mothers is the postpartum hemorrhage and perineal tear. This is very important, and also this psychological problem. For the fetus, the most important one is the hypoxia, and there's brachial plexus injury or fracture or even death. This is about fetal and neonatal morbidity. Here, the definition of shoulder dystocia is defined as impaction of the fetal anterior shoulder against the maternal surface pubis after the fetal head has delivered. Or by other words, you can define the shoulder dystocia if there is prolongation of times more than 1 minute between the delivery of the head and the delivery of the shoulder. If you deliver the head and take more than 1 minute and the shoulder is not delivered, this is defined as shoulder dystocia. And is diagnosed when additional maneuver are required to deliver the fetal shoulders after normal gentle down traction has failed. Okay.
No voice.
Oh, sorry. What about the incidence of shoulder dystocia? Now my voice clear?
Yeah.
Okay, thank you. So what is the incidence of the shoulder dystocia? The overall incidence of shoulder dystocia is between 0.8% to 50%. This is the incidence, less than 1%. This is the recall question asking about the incidence of the shoulder dystocia. And the most important thing here, the impact of shoulder dystocia again is the mother and the fetus. And the most important complication here is the postpartum hemorrhage and third and fourth degree tears. Is the incidence of postpartum hemorrhage in case of shoulder dystocia about 11%. This is the recall correction. And third and fourth degree tears is about 3.8%. Also, this is the recall question. This is percentage is very important to memorize this. The impact of shoulder dystocia on maternal and on the fetus, brachial plexus injuries, one of the most common fetal complications. It is range between 2.3% to 16% of each deliveries. There is big range between 2.3 to 16% of for each deliveries. And most cases of brachial plexus injuries resolve without permanent disability. So this is very important because most of cases resolve spontaneously and less than 10% result in permanent neurological dysfunction. And larger infants are more likely to suffer as permanent brachial plexus after shoulder dystocia. So in strategy, the incidence of shoulder brachial plexus injury complicate up between 4 to 16% of all the shoulder dystocia, and the majority resolves spontaneously and said less than 10% result in permanent neurological dysfunction, like Episiotomy palsy and Columbicis palsy. This is about the complication of neurological or brachial plexus injury. And neonatal brachial plexus injuries is the most common cause of litigation obstetric related in UK and estimated as the third most litigated obstetric related complication in UK. This is the third one, which is the most common, but is the third one obstetric-related complication in UK. 46% of cases of shoulder dystocia associated with substandard care. So what is meant by substandard care? Substandard care is if there is any practice which can be harmful or ineffective, or you do practice which have no supported evidence, or you do practice which doing as inappropriately. That is mean by substandard care. If you do practice harm or ineffective or inappropriately or not supported by evidence base, so 46% of shoulder dystocia associated with substandard care. So here, please note that almost half of shoulder dystocia occur in normal birth weight infant. 48% occur with the birth weight less than 4 kilograms. This is very important because basically, you know, microsomy is the risk factor for shoulder dystocia, but about 48% of shoulder dystocia can occur in infant with normal weight or less than 4 kilograms. Here, how to diagnose the shoulder dystocia. This warning sign like hip traction between contraction and second state, and if there's difficulty in delivery of face and chin, or failure to substitution, or telltale sign. This is a warning sign of shoulder dystocia in the second state. Here, brachial plexus injury is very important, and injury primary to the lateral trunk, C5, C6, C7, this is the recall question of the brachial plexus lead to epipulse. Epipulse is meaning abducted shoulder, abducted shoulder, extended elbow, and flexed wrist, waiter's tips. This is the definition of epipulse. And we said less than 10% is become permanent. So fortunately, more than 90% is resolved spontaneous. This is about epipulses originated from the injury for the lateral trunk, C5, 6, C7. This is the recall question. Is it clear? And about the clamps, palsy is this injury of the medial trunk, C8, T1, and it is paralyzed. It is claw hand with good shoulder and elbow function. This is the difference between the epipulse and clumpus palsy. So this is also the recall question. You should memorize this sides, C8 and T1 for clumpus palsy, and C5, 6, 7 for epipulse. There is also neurological problem. Our less commonly maternal complication also include physical separation, and there is transient maternal femoral neuropathy. This is the less common complication for mothers. So the important question is the shoulder dystocia is preventable, or you can predict shoulder dystocia? Anybody to answer this question? Is it preventable? You can predict shoulder dystocia, and why? Anybody knows? So prediction of shoulder dystocia is very difficult and inaccurate because only 25% of deliveries complicated by shoulder dystocia have a significant factor. So that is mean the majority of cause of shoulder dystocia can occur with women without risk factor. So difficult to predict or to prevent shoulder dystocia. So clinicians should be aware of existing risk factor, but must be alert to the possibility of shoulder dystocia with any delivery. So clinicians should aware of risk factor in labor in women and must always be alert to possibility of shoulder dystocia, even there is no risk factor. So this is the problem according to the shoulder dystocia, because this is unpredictable or difficult to prevent shoulder dystocia. The risk assessment is insufficiently predictive to allow prevention of large majority of cases, both single and in combination. So very important to do risk assessment. Conventional risk factor predict only 16% of shoulder dystocia that result in infant morbidity. So in case of shoulder dystocia, if you predict the risk factor, only you can prevent about 16%. So even you assess the patient and predict the risk factor, so the only 16% of shoulder dystocia can be prevented. What about the factor associated with shoulder dystocia? What is the risk factor of shoulder dystocia for pre-labor and intrapartum? What is the risk factors? Anybody knows? Hello?
Hello. Hello.
Hello, Dr. Maha. Welcome.
وعليكم السلام ورحمة الله. دكتور فتح الرحمن.
How are you? Fine.
The risk. Alhamdulillah. Risk factor in pre-labor اللي هي
Yes.
previous shoulder dystocia,
Yes, this is
macrosomic
very
baby more than 4.5 kg, diabetic mother, maternal body mass index more than 30,
Yes.
induction of labor.
Yes. That is about the pre-labor risk factor. Okay.
Yeah.
What about the intrapartum?
Prolonged first stage of labor,
Yes.
secondary arrest,
Yes.
prolonged second stage of labor also, oxytocin augmentation, assisted vaginal delivery.
Yes. Thank you so much, Dr. Maya. This is so very important to know about the risk factor of shoulder dystocia. So this is a chart shows the factor associated with shoulder dystocia. Divide into pre-labor and intrapartum. In pre-labor, the most important one is the previous shoulder dystocia. The recurrence of shoulder dystocia. This is the most important risk factor. So in the history, you should ask about the previous history of shoulder dystocia, and the recurrence risk in subsequent pregnancy is reported between 1 to 25%. This is the report about the recurrence of previous shoulder dystocia. The incidence is between 1 to 25%. This is the recall question asked about the recurrence of shoulder dystocia. Is it 10-fold or 8-fold or 4-fold? What is the answer? What about the recurrence of shoulder dystocia?
10-fold.
Yes, this is the fixed recall question. Came in every exam. Ask about the recurrence of shoulder dystocia. This is about 10-fold. Thank you, Dr. Wishbe. So Asif, I think Dr. Wish or Dr. Asif. Thank you. And previous shoulder dystocia, macrosomia more than 4.5 kilogram. We said before, 48% of cases of shoulder dystocia occur in the pairs weight less than 4 kilogram. But also macrosomia Here is very important, is more than 4.5 kilogram. It is a risk factor of shoulder dystocia. And diabetes mellitus, especially gestational diabetes, because as said is a macrosomia. If there is obesity, maternal body mass index more than 30 kilogram, and induction of labor. Here, induction of labor is also here mentioned as a risk factor. But in case of diabetes or gestational diabetes, is preventable measurement. So induction of labor itself, it is estimated as a risk factor. Intrapartum, this prolonged first stage of labor, and this is very important, and especially prolonged second stage or associated with assisted delivery. If there's prolonged second stage and require assisted delivery, so this is increased risk of shoulder dystocia. Also, venous deliveries are more likely to be complicated by shoulder dystocia than forceps delivery. If you deliver the patient by venous delivery, there is high risk for shoulder dystocia more than forceps delivery. And secondary arrest, prolonged second stage of labor also, oxytocin augmentation, and assisted vaginal delivery. So we said venous delivery increased risk of shoulder dystocia more than forceps delivery. What's the relationship between the fetal size and shoulder dystocia? In the previous chart, we said the macrosomia more than 4.5 kilogram is the risk factor for shoulder dystocia. So difficult to determine fetal size accurately, also because the large majority of infants with birth weight more or equal 4.5 kilogram do not develop shoulder dystocia. So not all the macrosomic baby complicated by shoulder dystocia. 48% of shoulder dystocia occur with infant weight less than 4 kilogram. Okay, and infant of diabetic mother have 2 to 4-fold increased risk of shoulder dystocia compared to the same birth weight for infant born to non-diabetic mother. So if the mother diabetic, shows the fetus for this mother have increased the risk of shoulder dystocia by 2 to 4-fold if compared with the normal woman, okay, or non-diabetic woman. So this is chart shows the comparison between incidence of shoulder dystocia in non-diabetic mothers and diabetic mothers. So according to the weight of the infant, if less than 4 kilograms, the rate of shoulder dystocia, if non-diabetic, it is about 0.3%. So it's about 0.3%. It's the only 0.3. Here, if the weight is less than 4 kilogram, and patient here is diabetic, so there's high risk for shoulder dystocia if compared with the non-diabetic. Here only 0.3%, here 3.7%. There's big variation between 3.3% and 3.7%. If the weight, infant weight between 4 to 4.5 kilograms, the rate of shoulder dystocia here is about 4.7%, and here is about 30.6%. So it's very high in women diabetic, and the weight more than 4 kilogram, 4 to 4.5 kilogram. And if more the microsomia, the infant weight more than 4.5 kilogram is about 9.4% in case of non-diabetic woman, and the rate of shoulder dystocia in diabetic is about 50%. So it is so high here in case of macrosomia and with the mother diabetes. This is difficult to memorize this, but here to compare, if you infant weight more than increase the infant weight can increase the rate of shoulder dystocia, and if the mother diabetic have higher risk if compared with the normal or non-diabetic woman. Okay, is it clear? So how to prevent of the shoulder dystocia? Management of suspected fetal macrosomia. Induction of labor does not prevent shoulder dystocia in non-diabetic women with suspected macrosomia fetus, not improve either fetal or maternal outcome. So here, induction of labor in case of women non-diabetic mothers does not prevent shoulder dystocia. And induction labor can reduce the incidence of shoulder dystocia in women with gestational diabetes. So here, the difference between non-diabetic mother and diabetic, the effect of induction of labor. Induction of labor have no role or not prevent shoulder dystocia in case of non-diabetic, and it is can reduce the incidence of shoulder dystocia in gestational diabetes. Nice recommended diabetic mother who have normally grown fetus should be offered elective birth through induction of labor by cesarean section if indicated after 38 weeks completed. So this is nice recommended to do induction of labor for women with gestational diabetes or by elective cesarean section if indicated after 38 weeks completed. So here, according to the talk article, there is no evidence to do early induction of labor to prevent shoulder dystocia. So here, very important to do after 38 weeks. Here, if you want to do induction of labor to prevent shoulder dystocia should be after 38 weeks, not early, because evidence no support to do early induction of labor to prevent shoulder dystocia. Elective cesarean section should be considered to reduce potential morbidity for pregnancy complicated by pre-existing or gestational diabetes. Regardless of treatment with estimated fetal weight more than 4.5 kilograms. This is recommended to do elective cesarean section if there is mother complicated by gestational diabetes or pre-existing diabetes and the infant more than 4.5 kilograms. An estimated weight over 5 kilograms should be promote consideration of delivery by cesarean section. Here, according to the American College of Obstetrics and Gynecology, and according to the NICE, if gestational diabetes or pre-existing and the weight more than 4.5 kilograms, this is for cesarean section. Maybe came for AMQ question here. So you should remember, memorize that. If this case of gestational diabetes or pre-existing diabetes and the fetal weight more than 4.5 kilograms, this is for elective cesarean section. Nice ultrasound estimation of fetal weight size for suspected large gestational born babies should not be undertaken in low-risk population. So what about the recommendation for the future? What appropriate mode of delivery for women after previous shoulder dystocia episodes? Either elective cesarean section or vaginal delivery can be appropriate after previous cesarean section. The patient have already have previous cesarean section and have any risk factor for shoulder dystocia should be either elective cesarean section or vaginal delivery can be appropriate. The decision should be made jointly by the woman and her carriers. Rate is 10 times than general population. Reported recurrence rate of shoulder dystocia between 1 to 2%. Many may be underestimated. No requirement for routine cesarean section. But in strategy, the recurrence rate is between 1 and up to 25%. Okay? Here, according to the, because the strategy is updated, and this guideline about 2012, as I just mentioned, the estimated risk as recurrent rate of the shoulder dystocia is about 1 to 2%. Okay, and here this reported recurrence of rate of shoulder dystocia between 1 to 2%. No require for routine cesarean section, but severity of any previous neonatal or maternal injury. So in history, it's very important to ask about this previous neonatal or maternal injuries, and predicted fetal size or maternal choice should be considered and discussed with the woman and her family when making plan for the next delivery. This is about how to recommend for the future for the mother. So the most important here in this session, how to manage the shoulder dystocia. As you mentioned before, shoulder dystocia should be managed quickly within 5 minutes. Okay? All pairs attendant should routinely look for sign of shoulder dystocia. Timely management require promote recognition. Routine all pairs attend should be observed. Head remain tightly applied to the vulva or even retracted turtleneck side. And failure of the substitution of the fetal head, this is the warm side, and failure of shoulder to descend. And traction axial direction should be used to diagnose shoulder dystocia, but any other traction should be avoided. Just do tension, gentle traction. If delivery is head, is okay. If not delivery, this is can be diagnosed of shoulder dystocia. So this is about many men of the shoulder dystocia. The routine traction required for the delivery of the shoulder in a normal vaginal delivery where no difficulty with shoulder. Downward lateral traction and rapidly applied traction are more likely to cause nerve avulsion. No evidence that use of McRoberts maneuver before delivery of the head for shoulder dystocia. If the patient not diagnosed for shoulder dystocia, no evidence to support to use McRoberts position. Therefore, prophylactic McRoberts position before the delivery of the head is not recommended to prevent shoulder dystocia. This is very important here. So you should do McRoberts maneuver after diagnosis of shoulder dystocia. There is no role for prophylactic McRoberts maneuver or position to prevent shoulder dystocia. Here, this is about also style management. What is meant by HELPERR? Anybody knows? What is meant by HELPERR?
It's a it's a mnemonic for it's a shoulder dystocia drill, like H for call for help, then E for evaluation of episiotomy, and L is for the legs, like to check whether the patient is in McRoberts, and P for pressure, and enter maneuvers, and finally the all four position roll.
Yes, excellent, Dr. Bushby, thank you. Here H for HELPERR, so call for help for the obstetric or midwifery and pediatric support and inform anesthetist. This is about H. E for episiotomy, or should evaluate for episiotomy. You should consider episiotomy in case of shoulder dystocia to facilitate the maneuver. And L for leg. Here leg is for the McRoberts position, like here for to raise the legs. here for the McRoberts maneuver, and P for pressure, suprapubic pressure, and E for intermaneuver or rotational maneuver like Robin 2 and wood screw and reverse wood screw. And first R is for remove of posterior arm, so delivery of the posterior arm, and the second R for the roll. So you should roll the muscles and do all, repeat all maneuver. So this is also style management. So why within 5 minutes you should deliver the fetus? Why?
Because
Why
if the baby is not born within 5 minutes, 48% babies will die. The mortality will be almost
Yes.
50%.
Yes, about hypoxia. Yes, it's very, very important because hypoxia more than 5 minutes, there is high risk for hypoxia and may lead to the fetal neonatal death. So some studies find if you deliver within 5 minutes, there is a low risk for the fetus for regarding the hypoxia ischemic change. So that is mean why you should deliver quickly within 5 minutes to decrease the risk for the fetus about the risk of the hypoxic ischemic change. Here first we start for corporal help, for obstetrician, for midwife, for junior doctor, for anesthetist, so for pediatrician, neonatologist. So here very important to call for help. The second step is here also address the patient and discuss to stop the pushing. Here is very important here to diagnose shoulder dystocia. So you do gentle traction for the head. If there is difficult to deliver the shoulder, this is shoulder dystocia. Or the time prolongation between the delivery of the head and the shoulder, this is about more than 1 minute, this is the shoulder dystocia. So advise women to stop pushing or discourage to push. And then you need to one assistant for documentation and one assistant to help you, because you should document everything here, every maneuver and the time of the duration of maneuver if failed or success. This is very important. Second is to evaluate for episiotomy, and you should consider here episiotomy. And first or the most important maneuver here is the legs or McRoberts and suprapubic maneuver. If you do combination, or first we'll start with McRoberts. Hello, McRoberts maneuver, and then if this failed, we'll do either intermaneuver or remove of posterior arm. This is depend on your skills and your experience. So most of the clinicians prefer to start to do first intermaneuver, then remove of the posterior arm. Then if failed, can roll the patient as Gaskin position and do all this maneuver again. If failed, you do secondary maneuver like the Vinelli and the Episiotomy and Episiotomy. This is about also style management. Regarding the green top guideline, the same like also management here call for help. Hello midwife, coordinator, additional midwifery, help, expertise, obstetrician, neonatal team, and assist. So this correct pushing, and then do McRoberts maneuver. Okay, McRoberts maneuver. Then after that is McRoberts maneuver is have succeeded more than 90%. Okay, then do suprapubic pressure, Robin 1 maneuver. If failed, you can here. If both, this is maneuver success more about 90%. If failed, here you should consider episiotomy. Then do the intermaneuver. Intermaneuver is Robin 2 and wood screw and reverse wood screw. We'll discuss later separately. And then after deliver intermaneuver or rotation maneuver, you can do deliver of posterior arm. If failed, you inform consultant, obstetrician, and assist to do the advanced maneuver. Before that, you roll and do all the maneuver, repeat all the maneuver, and if failed, you can consider colloidotomy or the Vinelli maneuver or episiotomy. This is about management of shoulder dystocia. Any question? Is it clear? Here, this is McRoberts maneuver. So in case of McRoberts maneuver, the woman should be lying flat. Here, this is the McRoberts position. This is about McRoberts position, and woman lying flat and placed in McRoberts position. And there is flexion and abduction of maternal thigh. Here is flexion and abduction of maternal thigh within the abdomen. Here again is abdomen. Here this is about McRoberts maneuver. We'll show in video. Yes, this is about McRoberts maneuver. Here in this McRoberts maneuver, there is strengthening of lumbosacral angle, so to rotate the pelvis and increase anterior posterior diameter of the pelvis. So this is the mechanism of the McRoberts maneuver to strengthen of lumbosacral angles and rotate the pelvis and to increase the anterior posterior diameter of the pelvis. So this is mechanism of McRoberts maneuver. So in McRoberts maneuver, there is flexion and abduction of the thigh, maternal thigh on her abdomen. It is strengthening of the lumbosacral angle and rotate the maternal pelvis towards the mother head and increase the relative anterior posterior diameter of the pelvis. Success rate as high as 90%. This is they call question also. Ask about the success rate of McRoberts maneuver. Has low complication rate, non-invasive maneuver. Put the mother in flat position. Remove any blows from the under her back, legs to be hyperflexed. If woman in lysotomy position, her leg will be removed from support. This is about McRoberts. So what is the suprapubic pressure or Robin 1? So if you do combination suprapubic pressure and McRoberts, we success rate more than 90%. So in case of suprapubic pressure, it is increase the fetal bioacromial diameter, so facilitate the delivery of the head. And in case of McRoberts, we said strengthen lumbosacral angle. So success rate, reduce the fetal bioacromial diameter and rotate the fetal anterior shoulder into the wider oblique pelvic diameter. The shoulder is then free to be underneath the symphysis pubis with the aid of routine axial traction. Ideally applied by a system from the side of the fetal back in downward and lateral direction, just above the maternal symphysis pubis. So here, if you wanted to do McRoberts, you need assistant. By pushing the posterior aspect of the anterior shoulder towards the fetal chest to decrease bioacromial diameter, no difference in efficacy between continuous pressure and rocking movement assessed by routine traction only. Here, this is the suprapubic pressure or Robin 1 maneuver. Okay. This is how to apply suprapubic pressure to deliver the shoulder dystocia. Should be done in 30 minutes. What about the episiotomy? Episiotomy will not relieve the bone obstruction for shoulder dystocia, but may be required, allowing more space to facilitate internal maneuver. So the main function of the episiotomy to facilitate the internal maneuver, like Robin 2, wood screw, and reverse wood screw. Moreover, use of episiotomy does not reduce the risk of brachial plexus injury with shoulder dystocia, so should be considered only if internal vaginal axis of the health professional whole hand cannot easily be achieved to facilitate delivery by maneuver. So here should consider episiotomy. It's not routine. Here you should consider episiotomy if you wanted to do internal maneuver. What measurement should be undertaken if the simple technique fail? If you do McRoberts maneuver and suprapubic pressure failed, what is the next steps? You should do the internal maneuver or the rotational maneuver. The internal maneuver or all four positions should be used. Give vaginal axis or for the internal maneuver in sacral hollow and most suspicious part of the pelvis. Therefore, vaginal axis should be gained posterior. The woman should be brought to the end of the bed or the end of the bed to remove and make vaginal axis easier. And delivery can be facilitated by rotation into oblique diameter when possible by fall 180 rotation of fetal trunk or by delivery of the posterior arm. So the internal maneuver described by Wood and Robin by pressing on the anterior or posterior aspect of the posterior shoulder. So we'll discuss it. Okay. Pressing on the posterior aspect have additional benefit of reducing of shoulder diameter by abducting the shoulder, rotate the shoulder into the wider oblique diameter, resolving shoulder dystocia. If pressure on the posterior shoulder to abduct and rotate the shoulder into the oblique diameter. Here, this is about the internal pressure.
No voice يا دكتور فتح الرحمن.
Yeah, okay, sorry. This is about Robin 2, internal maneuver. First, we'll start with Robin 2. So Robin 2, if you imagine, this is the vaginal orifice, and this is at 3 o'clock, and this is 7 o'clock. So you insert your right hand here, and to reach the posterior aspect of the anterior shoulder, and then rotate. Rotate the shoulder. This is the Robin 2. Robin 2. Okay? This is the first maneuver in intermaneuver or rotational maneuver. If failed, insert your left hand while your hand here in the same position of Robin 2. Insert your left hand at 7 o'clock and pass through the chest to reach the anterior aspect of the posterior shoulder and rotate against the Robin 2. So you can rotate like that. Okay. This is the wood screw. This is the wood screw maneuver. If failed, you should remove your left hand and the right hand in Robin 2 here, pass through the back to reach the posterior aspect of the posterior shoulder, and then rotate the shoulder. This is the reverse wood screw. Is it clear? You know about the Robin 2 here, the Robin 2 here, and if failed, you should insert your left hand and pass through the chest to reach the anterior aspect of the posterior arm, rotate against Robin 2. This is wood screw. If failed, remove your left hand and the right hand here, pass through the back to reach the posterior aspect of the posterior shoulder and rotate the shoulder. This is the reverse wood screw. This is about the intermaneuver. Is it clear? Here, this is the wood screw and reverse wood screw. Will be clear here. Yes, this is the wood screw. Here, left, right hand, and here is the left hand, and then rotate. If failed, remove left hand and the right hand to reach the posterior aspect of the anterior shoulder and rotate. This is about wood screw and reverse wood screw. Is it clear? If you do McRoberts maneuver failed, suprapubic failed, and do all the three intermaneuvers failed, you will do delivery of the posterior arm. So delivery of the posterior arm, reduce the fetal shoulder diameter by width of the arm and clasp the fetal wrist, and the posterior arm should be gently withdrawn from the vagina and in a straight line to avoid the fracture of the hand. Associated with 2 to 12.7% of the humerus fracture may reflect the nature of the cases rather than proceed itself. There is no available studies comparing internal rotation and delivery of the posterior arm. So if you want to do posterior arm before the rotational, can do it, but it is depend on your experience, on your skills and confidence, okay? Therefore, based on selection, training, clinical experience, and privileged circumstance. This is about posterior arm delivery. All four technique, 3% success rate depend on individual circumstance, and slim mobile woman without epidural anesthesia and single midwifery attendance may be more appropriate. Community setting for less mobile woman with epidural embrace, internal maneuver more appropriate. So the success rate of 4 technique, internal maneuver and posterior arm delivery, the success rate about 3%. Here, how to deliver posterior arm. Look for the technique for deliver posterior arm. Here also the Gaskin maneuver, roll mother and repeat all maneuver. So this video show how to deal with patient with shoulder dystocia. Already sent to the group. Yeah, here call for help. Yes, yes. You should inhibit shoulder dystocia by gentle traction of the head. Yes. First step, call for help. Yes. Yes, call for help. Yes, evaluate for episiotomy and put the patient on McRoberts position. Yes. Then gentle traction to deliver the head. Should be up to 30 minutes, 30 seconds, sorry. If felt, you can do suprapubic pressure. Yes, here should do Robin 2 maneuver. If felt Robin 2, you can do wood screw. Yes. Yes, this is the reverse wood screw. Yes, try to deliver posterior arm. Just roll the muzzle and repeat every maneuver. Yes, documentation and evaluate for any complication. Review the muzzle. Okay. So this is about management of the shoulder dystocia. So what about the measurement should be taken if the first and second line maneuver have failed? Difficult to recommended absolute time limit, very low rate of hypoxic ischemic change, injury up to 5 minutes including cladiotomy. It is surgical division of the clavicle or pending with finger. Episiotomy is division of the anterior fibers of symphysial ligament. Zavinelli maneuver is rarely done. This requires vaginal replacement of the head and delivered by cesarean section. So success rate vary. And there is new technique including use of posterior axillary sling, but there is available data about this maneuver. So what the optimal management for woman and her baby? Be alert to increase the incidence of postpartum hemorrhage and third and fourth perineal tear. Others include vaginal laceration, cervical tear, bladder rupture, uterine rupture, physical separation, sacroiliac joint dislocation, lateral femoral nerve continuous neuropathy. The baby should examine for injury by neonatologist, and explanations of the delivery should be to the parents. What about the documentation here is very important. Should be accurate and comprehensive. Use of structured performance suggests to improve accurate recording and effective. Important to record the time of delivery of the head and body and anterior shoulder at the time of dystocia. Maneuver performed their time and sequence. Maternal, cranial, and vaginal examination, estimated maternal blood loss, staff and attendants and their time of arrival, and general condition of the baby, Apgar score, umbilical cord blood acid base measurement, and neonatal assessment of the baby. This is about the documentation. So after shoulder dystocia, postpartum care may be included for infant and for the mothers. For infant, neonatal resuscitation, paired cord BH, lactate, pediatric review, and for the mother here to prevent postpartum hemorrhage because postpartum hemorrhage complicated by 11% and observe for perineal pain that could suggest hematoma. So this is about shoulder dystocia. Any question? So the question one, who wanted to share us? Question one. دكتورة مها. دكتورة دعاء. دكتورة سادية. بوشبي.
Yes. Assalamu alaikum.
دكتورة سادية.
Hello.
Hello, دكتورة سادية.
How are you?
Fine.
Question number one.
Question? Yes,
You-
question one.
Yes. Question number one. You undertake an instrument delivery on a 30-year-old priming gravida for prolonged second stage. You notice the turtle sign and diagnose shoulder dystocia with the next contraction when you are unable to deliver the shoulders. What maneuver is where you insert your fingers posterior to the anterior shoulder of the baby? It's Robin 2.
Yes, here's the Robin. To excellent, Dr. Sadi. Okay, this is
Okay.
question about the internal maneuver. Where maneuver is, what maneuver is where you insert your finger posterior to the anterior shoulder of the baby. So this is the Robin 2 maneuver. Yes, this Robin 2 maneuver. Can you please explanation, please?
In reverse wood screw, the fingers are posterior to the posterior shoulder, and in a wood screw, the fingers are anterior to the posterior shoulder. Robin 2 can be used in conjunction with the wood screw maneuver. Symphysiotomy is division of the symphysis ligaments, and Zavanelli is replacement of the fetal head with delivery by cesarean section.
Okay, thank you, Dr. Sadia.
Thank you, Doctor.
Dr. Ola. Dr. Bushby.
Hello, Dr. Fath. How are you?
Hello, Dr. Bushby. Welcome.
Hello.
Yeah, thanks.
Please, the question.
Okay. Question number 2. You undertake an instrumental delivery on a 30-year-old primee for prolonged second stage. You notice the turtle sign and diagnose shoulder dystocia. With the next contraction, when you are unable to deliver the shoulders, what maneuver involves flexion of the fetal head with the pressure superiorly until the fetal head is back in the vagina and then delivered by cesarean section? Answer is Javanelli's maneuver. E.
Yes, E is the right maneuver because impaction head inside the vagina and do cesarean section. Please read explanation.
Yeah. Correct answer, Javanelli's. Neonatal outcome at this stage are likely to be poor.
Yes. Okay. Thank you,
Thank you so much.
Dr. Ola. Dr. Imtinan. Dr. Ibtihal. Sabih.
Yes, Dr. Fatah.
Dr. Ibtihal.
How are you? Good evening.
Good evening.
Okay, yes, I'm with you.
Yes.
Primary Gravida is in the assessment unit. She has so far been midwifery-led care, but scan today for presentation showed the baby to be cephalic with an estimated fetal weight of 4,235 grams. What is the approximate chance of shoulder dystocia occurring for this woman? Sorry, her weight, the baby 4.2, right?
2 years.
I think 31. 31?
Not so high. Yeah, as you it's about
10%?
10%. Yes. Yes, Dr. Ibtihal is about 10%. Yes.
Approximately 10% of the estimated fetal weight is accurate. If the woman also had diabetes, the risk would be 31.
Yes.
Because
Yes.
the patient,
If
she doesn't
diabetic,
have diabetes.
Yes.
Yes.
The non-diabetic. So here difference between the non-diabetic and diabetic mother. Thank you, Dr. Ibtihal.
Okay, welcome.
Next. Dr. Imtinan?
Yes, doctor.
Yeah.
Okay, question 4. What is the most common reason for litigation following a shoulder dystocia? Burst asphyxia, brachial plexus injury, clavicular fracture, humeral fracture, maternal trauma, brachial plexus injury.
Yes, this is the most common reason for litigation in case of shoulder dystocia. Yes. Yes.
Okay.
Read the explanation, Dr. Imtinan.
Okay, neonatal brachial plexus injury is the most common cause for litigation related to shoulder dystocia and is the third most litigation obstetric related complication in UK.
Yes, in regarding shoulder dystocia, it is the most common one.
Mm.
But regarding obstetric related complication in UK,
The
it's
third one.
Yes,
Okay.
yes, thank you. Now the picture 19. Dr. Wajbi, this question.
Okay. A 32-year-old woman in her second pregnancy was induced at 40 weeks because of gestational diabetes that is well controlled with metformin. She had prostaglandin gel and 3 hours later had artificial rupture of fetal membranes. Shortly after, she started contracting and progressed to full dilatation after 7 hours. She remained fully dilated for 2 hours and then started pushing. The head was delivered but was noticed to be receding, that is, there was turtleneck appearance. You were called and arrived after 2 minutes. What would be the next step to take in her management? A. Apply suprapubic. B. Insert your hand in vagina and deliver the posterior arm. C. Place in her all four. D. Perform an episiotomy and attempt deliver shoulders. E. Place her in McRoberts. So as per the chart, it should be McRoberts. Answer
Yes,
is E.
yes, E, yes. Excellent. You should do McRobert position. This is the first maneuver to deal with the patient with shoulder dystocia.
Yes.
Any justification?
Yeah, sure. Answer is E. Place her in McRoberts position. Upon recognition of shoulder dystocia, maternal pushing should be discouraged and help sorted. On arrival, the first step to take is to put the women in McRoberts position to allow for McRoberts maneuver, which is successful in as many as 90% of cases. If this fails, the next maneuver should be application of suprapubic pressure followed by internal maneuvers. If this fails, to deliver the shoulders.
Okay, thank you, Dr. Rajba. Thank you so much.
Thank you so much, Doctor.
Sorry, Dr. Fatih, can I see the answer of question number 18?
18.
Again, sorry. Ah, yes.
So,
What was the answer? Sorry, previous questions.
answer is about A. So, a
large majority.
of infant, yes, with a birth weight more than 4.5 kilogram do not develop shoulder dystocia. Because shoulder dystocia, about 48% of shoulder dystocia can occur in the
Normal weight.
infant weight less than 4 kilogram. So
Yes.
not all the case of fetal weight more than 4.5 kilogram develop shoulder dystocia.
Yes, yes, exactly,
Okay,
sir. Thank you.
So, the last three questions. Dr. Sadia.
A 23-year-old prima gravida whose pregnancy was complicated by gestational diabetes went into spontaneous labor at 40 weeks of gestation. She started pushing but had shoulder dystocia after delivery of the head of the baby. What factor likely to increase the risk of brachial plexus injury in the baby? The gestational age of delivery, the time it takes to deal with the dystocia, the weight of the baby, whether it's an anterior posterior shoulder impacted, whether the impaction is on the pubic symphysis of sector promontory.
Sorry, what was the important risk factor for brachial plexus injury according to this option?
I guess
about the fetal weight. Because microsomy is the risk factor for shoulder dystocia and the risk factor for brachial plexus injury.
plexus injury, okay. So the answer is weight of the baby. Yes, yes, okay.
Answer is the weight of the fetus.
Okay, macrosome.
Third,
What is the
43.
most common cause of litigation related to shoulder dystocia in the UK? It is the brachial plexus injury.
Yes, brachial plexus injury. Yes. Yes, excellent. This is
A 30-year-old woman whose labor was complicated by shoulder dystocia and brachial plexus injury has come back for debriefing. It is recognized that a significant number of these injuries are associated with substandard care. Approximately what proportion of these injuries are associated with substandard care? Sorry, I don't know.
it is. We said before about 48% of shoulder social associated
But
with
here,
substandard care. So
so
it
it's
is
45 to 50%.
yes 48%. So it is C. Yeah.
See, 45 to
C.
50%.
Yes, this is the answer for shoulder because shoulder social associated with 48% of substandard care.
Mm.
Yeah. Yeah, this is the answer about the 42 is the weight of the fetus, and 43 is brachial plexus injury, and C is about 45 to 50%. Okay, thank you, Dr. Sadi, so much. Okay.